Hi everyone, and welcome to a presentation on the Outbreak case study of poliomyelitis. My name is Jeremy Kaplan, and this is a presentation for Oklahoma State University Center for Health Sciences, Masters of Public Health 5323 General Epidemiology course. Polio, short for poliomyelitis, epidemic was prevalent between 1916 and 1955 worldwide, and the United States saw two major outbreaks in 1916 and 1952. The viral disease affecting the nervous system resulting in paralysis is indicative of polio. Poliomyelitis, coming from the Greek terms polios, meaning gray, and myelin, meaning marrow, refers to the tissue in the middle of the spinal cord that causes paralysis when affected. Of 57,682 reported cases in 1952, 5.5% or 3,145 were fatal. Of those, more than 21,000 resulted in paralysis. Dr. Jonas Salk's vaccine in 1955 marked a steep decrease in cases worldwide, and the last case of wild poliovirus acquired in the United States was in 1979. In 1953, 1.83 million children in 44 states received either a placebo or the vaccine, and this introducing a control group was a massive step forward in development of randomized control trials in medicine. Effective vaccines are used worldwide, where healthy countries eliminated polio in the 1960s and 1970s, whereas poor countries are still very much affected. And we can see that where in the early 1980s, annually, hundreds of thousands of cases emerged. We can see from this graph below, courtesy of Our World in Data, showing a steep increase in 1952 and then a steep drop as soon as the vaccine was administered and readily available in 1955. The history of polio can be divided into three major phases. The endemic phase from antiquity to the 19th century, in which the disease occurred relatively rarely and did not result in many paralytic cases. The epidemic phase until the mid-20th century saw large-scale outbreaks and increased geographic spread. The vaccine phase followed the introduction of vaccines in 1955, where prevalence drastically decreased. Though the exact origins are unknown as the disease requires a human host, epidemiologists assume the disease originated when humans started settling in larger groups. Polio is an infectious viral disease caused by poliovirus, an enterovirus that can lead to permanent paralysis where no cure exists for symptoms. Type 1, 2, and 3 serotypes, where immunity to one does not cause immunity to the other. Immobilization of muscles can be fatal by affecting breathing. Dr. Drinker and Lewis Shaw developed the iron lung to prevent death by suffocation. Polio is contracted predominantly in children, and transmission and spread is through direct contact with the infected. Oral and an oral fecal transmission route via contaminated drinking water affects humans as a reservoir only. Virus replicates in oral pharynx and gastrointestinal tract, invades local lymphoid tissues, and infects cells in the central nervous system. Destruction of motor neurons results in paralysis. Temporal pattern peaks in the summer in temperate climates, and no seasonal pattern is seen in tropical climates. When looking at the clinical features, 72% of infections do not lead to symptoms, and incubation period is 3 to 6 days. 24% result in abortive poliomyelitis, where you can have nonspecific symptoms such as fever and cold that last for a few days. 1 to 5% result in non-paralytic aseptic meningitis, where those have stiff limbs up to 10 days. And paralytic poliomyelitis paralysis incubation period is 7 to 21 days. Between 1 in 50 and 1 in 500 infections result in paralysis among those not vaccinated. Poliomyelitis was first described by Michael Underwood in England in 1789, but was not viewed as an epidemic until the late 19th century. The Northern Hemisphere suffered epidemics every summer and fall, where infections peaked in the United States in 1952. Polio has been known to be difficult to track due to long incubation periods and lacking symptoms, and therefore identification of index cases are very difficult. 2 of 3 types of wild poliovirus have been eradicated worldwide. In 1985, member countries of the Pan American Health Organization adopted the goal of eliminating poliomyelitis from the Western Hemisphere by 1990. These strategies included increasing vaccination coverage, enhancing surveillance for suspected cases, such as surveillance for acute flaccid paralysis, and using supplemental immunization strategies, such as national immunization days, house-to-house vaccination, and containment activities. As we can see from the depiction down below, wild poliovirus in 2018 is much different than what we can see for wild poliovirus in 1988, and we see extensive eradication. Through success in the Americas in 1988, the World Health Assembly adopted the goal of eliminating poliomyelitis globally. In 1988, polio paralyzed over 350,000 individuals per year in over 125 countries. By 2019, only 125 cases caused by wild poliovirus were reported globally, which was a reduction of over 99% from 1988. Type 2 wild poliovirus was eradicated in 2015 and Type 3 in 2019, but due to low coverage with routine immunization and poor quality of vaccination campaigns before the trivalent to bivalent switch led to reemergence of Type 2, causing outbreaks in 20 countries and paralyzing 369 children. As we can see from our world and data, these 2 charts that we have, the first one, reported cases in paralytic polio. We can see in 1980 over 60,000 cases dropping dramatically to 2023, but we see paralytic polio estimated cases by world region from 1980 to 2023. In 1980, we see well over 400,000. So what we can see is, again, that this is very difficult to track. In terms of monitoring, the polio vaccine and quarantine of those affected were the primary medical responses utilized to slow the spread of transmission. As shutdowns were not uncommon, the Centers for Disease Control and Prevention reported that travel and economics between affected cities were restricted at times by local officials, and quarantines were imposed on homes in localized communities where polio cases were diagnosed. President Truman's call for national mobilization was meant to rally individuals to be prudent, follow guidelines, isolate those infected, and inspire the medical community to find treatment and a cure. It was that very motivation that helped steward the vaccine creation by Dr. Salk. Researchers and epidemiologists suggest that future investigative monitoring should focus on identifying patients suffering from symptoms or relying on stool samples. To be certified as polio-free, a World Health Organization region needs to record no wild indigenous polio cases for at least 3 years, have a reliable surveillance system in place, and prove its capacity to detect and respond to imported polio cases. The World Health Organization also recommends that even a single case of wild polio in a child should be treated as a public health emergency in countries previously declared polio-free. As we can see from the top image of our world and data, globally, most countries are WHO region certified polio-free, whereas a few countries remain polio-free that are not certified or still endemic, and those are mainly in Africa and some areas in Asia. In 2013, the GPEI implemented the Polio Eradication and Endgame Strategic Plan 2013 to 2018, costing an additional $5.5 billion to top the already $9 billion spent since the 1988 implementation. The plan hopes to finance the last stretch of vaccination campaigns in countries where polio is still endemic to keep other countries polio-free. While costs are high, the GPEI argues that eradication is more cost-effective by illustrating long-term costs of controlling rather than eradicating. In the economic domain, fewer polio patients translate into lower healthcare costs. Once polio is eradicated, the world can stop producing and administering polio vaccines, as well as surveilling paralytic diseases suspected of polio. Therefore, discontinuation of costly activities will result in extensive economic gain from eradication. Tibbins et al. 2010 modeled a net benefit of $40 to $50 billion to the United States alone. As we can see from the Our World and Data chart on this slide, how many cases of paralytic polio were averted by the Global Polio Eradication Initiative, we can see an estimated 2.2 million cases of paralytic polio were averted between 1988 and 2018. Were no erratic campaign, 3 million estimated cases would have been seen. The poliovirus vaccine is available as IPV or combination vaccines. The first dose of IPV vaccine can be administered as early as 6 weeks, but typically around 2 months of age. The second dose at 4 months, third dose between 6 and 18 months, and the final dose between 4 and 6 years old. The IPV vaccine is highly effective in providing immunity to poliovirus and protection from paralytic poliomyelitis, where more than 90% develop antibodies to all 3 poliovirus types, and more than 99% are immune following the third dose. As we can see from Our World and Data charts on the slide, the top chart shows share of 1-year-olds who are vaccinated against polio in 1980, and the bottom in 2001. We can see from these two charts a very steep increase of vaccination between these two times. In summary, polio, short for poliomyelitis epidemic, was prevalent between 1916 to 1955 worldwide, and the United States saw 2 major outbreaks in 1916 and 1952, whereas 1952 there were 57,682 reported cases. Polio is a viral disease affecting the nervous system, resulting in paralysis. Dr. Jonas Salk's inactivated polio vaccine in 1955 marked a steep decrease in cases worldwide, though a discrepancy remains between wealthy and poor countries. Polio is transmitted and spread directly through contact with the infected and contracted predominantly by children. While 72% of infections do not lead to symptoms, the virus is still highly infectious. Polio is difficult to track due to long incubation periods and lacking symptoms, and therefore identification of index cases are very difficult. In 1985, member countries of the Pan American Health Organization adopted the goal of eliminating poliomyelitis from the Western Hemisphere by 1990. These strategies included increasing vaccination coverage, enhancing surveillance for suspected cases, such as surveillance for acute flaccid paralysis, and using supplemental immunization strategies, such as national immunization days, house-to-house vaccination, and containment. In 1988, polio paralyzed more than 350,000 individuals per year in over 125 countries, but by 2019, only 125 cases caused by wild poliovirus were reported globally. That was a reduction of over 99% from 1988. To be certified as polio-free, the World Health Organization region needs to record no wild indigenous polio cases for at least 3 years, have a reliable surveillance system in place, prove its capacity to detect and respond to imported global polio cases. In the economic domain, fewer polio patients translate into lower healthcare costs. Once polio is eradicated, the world can stop producing and administering polio vaccines, as well as surveilling paralytic cases suspected of polio. Therefore, discontinuation of costly activities will result in extensive economic gain from eradication modeling, an estimated $40 to $50 billion United States gain. IPV and combination vaccines exist and are recommended with a first dose between 6 weeks to 2 months of age. Thank you so much for joining me today on an outbreak case study of poliovirus. I'm Jeremy Kaplan.